So, another neurology topic, and the topic is basal ganglia. Correct? Topic is basal ganglia and related disease. So, what do you mean by ganglia? What do you mean by ganglia? What is the meaning of? Yes? Not exactly group of neurons. Ganglia essentially means group of neuronal cell bodies. Okay, just like nerve fiber. Nerve fiber we mean collection of actions, right? Nerve fiber is collection of actions, but ganglia means collection of cell bodies. And the basal ganglia, so it is at the base of brain. So located at the base of brain, ganglia. Okay, basal ganglia. It is a very important neurological structure. In our previous class, we have discussed cerebellum, right? In our previous class, we have discussed cerebellum and the role of cerebellum in learning and in motor learning. Role of cerebellum in motor learning. And you know, cerebellum smoothens your movement. Without cerebellum, there will be decomposition of movement, right? There will be decomposition of movement. Your movement will be robotic type, right? So, cerebellum smoothens your movement. Now, what basal ganglia is also a motor organ, just like cerebellum is a motor organ. Basal ganglia is also a motor organ, right? And it is also related to your movement. Okay, its function is also related to your movement. So, basal ganglia essentially means millions of nerve cell bodies, millions of neuron cell bodies, and cerebral cortex, your cerebral cortex decides on body movement, decides the type of movement, right? And basal ganglia execute the movement. Your cerebellum smoothens the movement and your basal ganglia executes the movement, right? And basal ganglia is a pair of deep structure. It is located on both the side, right and left, and each pair consists of few nuclei. Okay, each pair consists of these four things. One is striatum, next is GP or globus pallidus, then thalamus, and then substantia nigra in midbrain. So, basal ganglia on each side is composed of striatum, globus pallidus, thalamus, and substantia nigra in midbrain, right? Substantia nigra is located in midbrain. So, here is the basal ganglia, schematic diagram. Striatum is composed of two different nuclei. One is caudate nucleus and another is called putamen, right? Globus pallidus again is divided into two, external globus pallidus and internal global pallidus. Then thalamus, again thalamus is also a part of basal ganglia, and in the midbrain, substantia nigra. So, this is the composition of basal ganglia. You will also study the detailed anatomical structure of basal ganglia in your anatomy class. You will also dissect and see the location of basal ganglia during brain dissection. So, basal ganglia can start, can stop and control your desired movement, and it can also inhibit your unwanted movement, right? So, basal ganglia can initiate, can start your movement, can stop your movement, can control your movement, and it will stop your undesired movement, right? Okay. It will also prevent your undesired movement. Okay, now basal ganglia has connection with cerebral cortex. Okay, the basic thing is your basal ganglia has connection with cerebral cortex, and it can connect with the cerebral cortex in two ways. One is direct pathway and another is indirect pathway. So, your basal ganglia, which is located at the base of brain, it can connect to cerebral cortex in two ways. One is direct pathway. So, basal ganglia sends connection to cerebral cortex directly, and another pathway is your basal ganglia sends neuron to cerebral cortex, but not directly through there are some stations, right, in between. So, we call it indirect pathway. Okay. So, first the direct pathway. Okay. First the direct pathway. So, you know striatum is the part of basal ganglia. Okay. So there is both way connection, basal ganglia to cerebral cortex and cerebral cortex to basal ganglia. Okay, basal ganglia to cerebral cortex to basal ganglia. Now depending on the connection from basal ganglia to cerebral cortex, we divide it into either direct pathway or indirect pathway. Okay, and remember direct pathway will be excitatory pathway. Okay, direct pathway will be excitatory pathway. So that means the direct pathway, when the direct pathway is stimulated, your movement will be exaggerated. And when there will be indirect pathway stimulation, indirect pathway is inhibitory, it will inhibit your movement, right? The basic concept is this. Direct pathway is excitatory and indirect pathway is inhibitory. Direct pathway will enhance your movement and indirect pathway will stop your movement, will inhibit your movement, right? Okay, so for physiology question answering purpose, you need to remember the pathway, what is direct pathway and what is indirect pathway, and if you are able to draw a diagram, that is better, that will carry more marks, right? So direct pathway is, so cortex to cerebellum, first there is a connection from cortex to striatum, there is a pathway, right? Now from striatum, how will we reach to cerebellum? Directly or indirectly? So this is indirect pathway. So first step is from striatum to globus pallidus internus. This pathway is inhibitory. From globus pallidus internus to thalamus, this pathway is again inhibitory. Then thalamus to cortex. Okay, हमें कहाँ पहुँचना है? Striatum से cerebral cortex. So the pathway is from striatum to GPI to thalamus to cortex. This is how we reach cortex. And this is very short pathway and we call it direct pathway. This pathway is excitatory. Why this pathway is excitatory? Because these two pathways, striatum to GPI and GPI to thalamus, both of these pathways are inhibitory. And these two inhibitory pathways cancels each other. Okay, these two inhibitory pathways, they cancel each other. No need to write, I will share the PPT, right? Now thalamus to cortex, this is excitatory. So in between, we have two inhibitory pathways, they will cancel each other. So thalamus is now free to excite cerebral cortex. Okay. তাহলে কর্টেক্স থেকে একটা পাথওয়ে বেসাল গ্যাংলিয়াতে আসবে, বেসাল গ্যাংলিয়া থেকে আরেকটা পাথওয়ে ব্যাক করে সেরিব্রাল কর্টেক্সে যাবে। ওকে, বেসাল গ্যাংলিয়া থেকে ব্যাক করে সেরিব্রাল কর্টেক্সে যেটা যাবে সেটা দুরকম হয়, একটা ডিরেক্ট হয় একটা ইনডিরেক্ট হয়, ঠিক আছে? তাহলে এখানে যেটা দেখানো আছে সেটা ডিরেক্ট, সেটা মাঝখানে বেশি স্টেশন নেই, স্ট্রায়াটাম হয়ে জিপিআই থেকে থ্যালামাস থেকে কর্টেক্স, খুব সোজা, মাঝখানে দুটো স্টেশন, একটা জিপিআই একটা থ্যালামাস। স্ট্রায়াটাম মানে বেসাল গ্যাংলিয়ার একটা পার্ট। ওকে, সো স্ট্রায়াটাম থেকে কর্টেক্স এর মাঝখানে দুটো স্টেশন রয়েছে, একটা জিপিআই একটা থ্যালামাস, তাই তো? So it is a very short pathway, it is a direct pathway. Okay, and in this pathway two inhibitory pathways, they cancel each other. So ultimately this pathway will excite cerebral cortex. Okay, thalamus is free to excite cerebral cortex. So this is direct pathway and this is excitatory. Okay, see this pathway, this is the direct pathway. So you see this is striatum. Okay, this is striatum, from striatum to globus pallidus internus, and from globus pallidus internus to thalamus, and thalamus to motor cortex, right? So it's a very simple pathway, right? Very simple pathway, striatum to cerebral cortex, and from cerebral cortex to striatum makes the circle complete, right? Okay, so depending on basal ganglia to cerebral cortex, we divide the pathway into direct or indirect. So this is the direct pathway, right? So for your examination purpose, you need to write the direct pathway, this name of the stations, and also you need to draw the diagram. If you draw the diagram, it will carry more marks. Okay, if you write a flow chart from cerebral cortex to basal ganglia and basal ganglia to cerebral cortex, that is also okay, but if you write a diagram, that will carry more marks. Okay, no need to write anything. If you do these things, at least I will give you 10 on 10. Okay, now indirect pathway. Okay, so indirect pathway, indirect inhibitory, remember I for I, indirect pathway is inhibitory, I for I, right? Indirect pathway inhibitory. So similarly, cerebral cortex to striatum, there is a pathway. Now we will go from striatum to cerebral cortex. So how? So from striatum to globus pallidus externus, in previous example it was globus pallidus internus. So now striatum to globus pallidus externus, it is an inhibitory pathway, and globus pallidus internus to subthalamic nuclei to GPI to thalamus, then thalamus to cerebral cortex. So there are lots of stations in between, lots of station in between striatum and cerebral cortex, right? So the stations are globus pallidus externus, subthalamic nuclei, globus pallidus internus, thalamus, then finally it reaches cerebral cortex. So there are 4 stations, at least there are 4 stations. So this pathway is quite long and this pathway is inhibitory to cerebral cortex, right? So thalamus, these 2 inhibitory pathways again they cancels each other, 2 inhibitory cancels each other. Finally thalamus cannot excite cerebral cortex. Okay, thalamus will not be able to excite cerebral cortex. So this pathway is inhibitory. Okay, this pathway is inhibitory. Again you see the diagram. So here is the striatum. So from striatum to globus pallidus externus, from globus pallidus externus to subthalamic nucleus to globus pallidus internus to thalamus, thalamus to cerebral cortex. Okay, and from motor cortex to striatum there is a single pathway. Okay, so this is indirect pathway. This will inhibit your movement. When the direct pathway will be stimulated, it is excitatory to your movement, and when the indirect pathway will be stimulated, it will remain inhibitory to your movement. It will inhibit your movement, right? Okay, now role of substantia nigra. What is the role of substantia nigra? You have seen that both in direct pathway and indirect pathway there is no role of substantia nigra, but this substantia nigra, which is located in the midbrain, it is a very important structure to consider, because the pathology here in substantia nigra is related to Parkinson's disease, right? So what is the role of substantia nigra? It is located in the midbrain, and striatum also receives dopaminergic neuron from substantia nigra pars compacta. Okay, there are 2 divisions of substantia nigra. One is pars compacta and another is pars reticulata. Okay, pars compacta and pars reticulata, right? And the important structure of consideration is substantia nigra pars compacta, right? And striatum has got both D1 and D2 receptor. D1 and D2 receptor mean dopamine receptor. Okay, what is the role of dopamine? Is it an inhibitory neurotransmitter or excitatory neurotransmitter? Excitatory, yes. So when dopamine level increases in brain, what happens? Okay, what happens? What happens when dopamine level increases? Yes, we are maniac, right? আমরা খুশি থাকি, আনন্দে থাকি যখন ডোপামিন বেড়ে যায়, আর যখন ডোপামিন কমে যায় আমরা ডিপ্রেসড হয়ে যাই, ডিপ্রেশন. Okay, so that is why we treat the patients of depression with dopamine. Okay, with some drugs that increases dopamine in the cerebral circulation, right? Okay, so dopamine is a hormone, a local hormone, neurohormone, which elevates our mood. Okay, we remain happy. Okay, and dopamine deficiency means depression. Okay, so that is different. Now come what happens in Parkinson's disease. Okay, what happens in Parkinson's disease? Striatum has got an important part in basal ganglia. It has got both D1 and D2 receptor, dopamine receptor. It has got dopamine receptors, right? And D1 activates the direct pathway via stimulation of globus pallidus internus, and D2 inhibits indirect pathway by projecting to globus pallidus internus. So ultimately, dopamine collectively favors excitatory projection to cerebral cortex. Okay, and which reinforce your desired movement. आप जो करना चाहते हो वो आप कर पाते हो, ठीक है? So dopamine does something to your cerebral cortex कि आप जो करना चाहते हो वो आप कर पाते हो, right? Okay, so this is the function of dopamine through substantia nigra. Okay, so dopaminergic neurons are located in substantia nigra, and very specifically important part is substantia nigra pars compacta. Okay, so individuals who use cocaine, individuals who use or abuse cocaine, they have high dopamine level in their blood. So there is enhanced movement, and they are not able to control their unwanted movement. Okay, so inhibition is lost. Okay, who use cocaine, their dopamine level is so high and they are so energetic that in that sense energetic, so they will not be able to control their unwanted movement. Okay. Okay, now with this knowledge of physiology, of basal ganglia, the direct pathway, the indirect pathway, what is the neurotransmitter, the inhibitory pathway and excitatory pathway we have known. Now we are coming to Parkinson's disease. What is Parkinson's disease? What are the symptomatology of Parkinson's disease? What is the basic pathology of Parkinson's disease? Okay, and what is the causation of Parkinson's disease? Parkinson's disease क्यों होता है, right? Okay, so everyone, I guess, have heard the name of this disease, Parkinson's disease, and very often in the clinic you need to differentiate a patient of Parkinson's disease and a patient of cerebellar disease. Okay, so there are few similar presentation. Both the patients will have got tremor, but still you need to differentiate the patients, which patient has cerebellar disease and which patient has got Parkinson's disease or basal ganglia disease, right? Okay, so it is basically, what is Parkinson's disease? It is basically a movement disorder. Your cerebellum is concerned with your movement and your basal ganglia is also concerned with your movement. Okay, your both cerebellum and basal ganglia are concerned with movement. So movement will be affected whether your basal ganglia is diseased or your cerebellum is diseased, right? Whatever is affected, basal ganglia or cerebellum, it is a movement disorder. So Parkinson's disease is also a movement disorder and one of the most common neurological disorder you will face in the neurology clinic, right? The most common neurological disorder you will face in a neurology clinic, right? And it is basically due to degeneration of dopamine producing neuron in the substantia nigra pars compacta. Okay, substantia nigra, very important part in basal ganglia, which is located in the midbrain, and it has got lots of neurons which contains dopamine. Okay, and specifically loss of these neurons, okay, specifically loss or degeneration of these neurons. Now nobody knows how these neurons are degenerated. There are multiple factors, okay, responsible for it. So the basic pathophysiology is degeneration of dopaminergic neuron. Okay, nigrostriatal dopaminergic neuron, matlab from substantia nigra to striatum. There are some dopaminergic neuron that connects substantia nigra to striatum. Okay, the neurons connecting substantia nigra and striatum. These are very important neuron which secretes dopamine. Okay, and loss of this neuron or damage of this neuron, degeneration of these neurons cause Parkinson's disease. Okay, so it is a progressive disease, adult onset, progressive disease, you can't check it. Okay, it is a progressive disease, gradually it gets worsened, right? Gradually it gets worsened. So it is a progressive disease, you can't halt it, right? It is a progressive disease and adult onset. Next, no exact known cause, and sometimes it is genetic due to mutation of specific gene called PINK1 gene, Parkin gene, and alpha-synuclein gene. PINK1, alpha-synuclein and Parkin gene, right? Okay, it is also rarely due to MPTP found in recreational drug MPPP, a synthetic opioid, like a নেশার জিনিস, right? MPTP is a opioid. Okay, so people who use MPTP or abuse MPTP, they may have Parkinson's disease or Parkinson's-like symptoms, right? And the risk factors, also there are some risk factors like pesticide exposure and LRRK2 gene variant individuals. Substantia nigra. Substantia means substance and nigra means black. Okay, it is identified in the midbrain by blackish structure. Okay, when you dissect midbrain, you will see substantia nigra, it is blackish. So darker than other regions in the brain. That is why it is called substantia nigra, right? It is a part of basal ganglia and located in each side of the midbrain. It controls movement, it connects motor cortex, and if you do microscopy, what you will find in substantia nigra is eosinophilic round inclusions made of alpha-synuclein, okay, made of alpha-synuclein protein, and this is called Levy body. Okay, this inclusion body is called Levy body. Very important MCQ zone. Okay, very important MCQ zone. MCQs come from this area. Okay. So the function of this specific protein alpha-synuclein, it is still not known, but these inclusion bodies are found in the neurons in the substantia nigra. Lewy bodies are also found in other neurological disorder. Again MCQ zone. Okay, again MCQ zone for your NEET PG or next PG, whatever. Okay. So alpha synuclein, it is not only seen in Parkinson's disease, it is also seen in these inclusion bodies, it is also seen in other neurological disorder like Lewy body dementia, LBD, Lewy body dementia, and multiple system atrophy, right? Substantia nigra, again, I repeat, Substantia nigra has two parts, pars reticulata and pars compacta, and pars reticulata receives GABAergic input from the striatum and sends GABAergic neuron to thalamus, whereas pars compacta, it sends dopaminergic neuron, which is important to us. Pars compacta sends dopaminergic neuron to striatum and helps to stimulate cerebral cortex, and pars compacta is the specific part which is affected in Parkinson's disease. Okay. So again MCQ, which part of Substantia nigra is affected in Parkinson's disease, pars reticulata or pars compacta? So it is pars compacta. Answer is pars compacta. Okay, so pars compacta is the affected area. Okay, now the symptomatology of Parkinson's disease, how to identify a patient of Parkinson's disease. So as dopamine enhance your movement, right? Dopamine enhance your movement, so loss of dopaminergic neurons, no dopamine in blood, so definitely there will be less movement. Okay, so we call it either akinesia or bradykinesia or hypokinesia. Okay, so akinesia means no movement at all, hypokinesia or bradykinesia means less movement. So Parkinson's disease, we used to remember during our MBBS days, Parkinson's disease is a symptom of RAT, R-A-T. Okay, R means rigidity, A means akinesia, and T means tremor. Okay, so RAT symptoms: rigidity, R for rigidity, A for akinesia or no movement, and T for tremor. Okay, so Parkinson's disease is essentially RAT symptoms. So tremor, there is a specific type of tremor. Hypokinetic means low movement, and tremor means specific type of tremor, and where you need to differentiate a patient of cerebellar disease and Parkinson's disease by simply seeing the tremor. In cerebellar disease, the specific type of tremor is called intention tremor. So when you try to hold an object or try to touch an object, at the end of the movement there is tremor, it is called intention tremor. Okay. In the contrary to very specific tremor in Parkinson's disease, which is called rest tremor or pill rolling tremor. Have you seen pill rolling? Pill rolling. Okay, someone who chants, right? There is a a mala or garland type of thing with beads, and they count the beads. Okay, in this way they count the beads, right? So it is specific pill rolling movement. Pill rolling movement. Okay. And it is also called pill rolling tremor, and it is seen in rest. Okay, so when the patient is not doing anything, just resting, then we see the tremor. So it is rest tremor in contrast to cerebellar disease tremor, where it is intention tremor. So intention tremor is a feature of cerebellar disease, and pill rolling tremor or rest tremor is a sign of PD, Parkinson's disease. Okay, what else is seen in PD? So rest tremor diminishes with movement. Rest tremor diminishes with movement, whereas in cerebellar disease, intention tremor increases with movement. Okay, so patient को move करने बोलोगे तो PD का tremor खत्म हो जाता है. Okay, PD का tremor खत्म हो जाता है once you ask the patient to move, right? And once you ask the patient to move, cerebellar tremor increase होता है, right? Okay. Next, rigidity, cogwheel rigidity. So here comes the concept of muscle tone. Okay, have you studied muscle tone? How to see muscle tone or how to evaluate muscle tone? No, it is in motor system examination anyways. So muscle tone is a resistance offered by the muscle during passive movement. Okay, resistance offered by the muscle during passive movement. So say for example, simply if I just so simply if I try to flex at the elbow joint, right? So if I try to flex at the elbow joint, triceps will resist, and similarly if I try to extend, biceps will resist, and this resistance is due to muscle tone, because your biceps and triceps muscle has got a specific resistance, specific muscle tone. Okay, so the clinical definition of muscle tone is the resistance of the muscle during passive movement, and during neurological examination you need to check the muscle tone of the patient, any neurological patient, be it a stroke patient, cerebrovascular accident patient, hemiplegia, paraplegia, whatever, cerebellar disease, PD, Parkinson's disease, right? So everywhere for neurological patient examination we need to check the muscle tone of the patient, right? And in Parkinson's disease there is increased tone, but it is somewhat different. Okay, we call it rigidity. Okay, again very important question. I'm coming to the clinical part, right? So in nervous system examination, during motor system examination, you may be asked to check the muscle tone of the patient. Okay, and you need to describe what is the muscle tone. Muscle tone is increased or decreased, or muscle tone is normal. So it is, there is no measurement, it is just by experience. If you see thousands of patients, then only you will be able to ascertain whether muscle tone is normal or increased or decreased, right? So it is attained by practice. Okay, it is attained by practice. The more you see patients, neurological patients, you are more able to diagnose whether the patient is having hypertonia or hypotonia. When the tone is increased, we call it hypertonia, and tone is decreased or loose. Okay, so no muscle tone at all, the muscles are relaxed, so we call it hypotonia. Okay, so hypertonia or tone increased, it may be of two types. Okay, one is spasticity and another is rigidity. Spasticity or increased muscle tone is seen in upper motor neuron lesion. Okay, spasticity is seen in upper motor neuron lesion, and rigidity is seen in PD, Parkinson's disease. There are two types of rigidity seen in Parkinson's disease. One is cogwheel rigidity and another is lead pipe rigidity. Okay, and spasticity is called clasp knife spasticity. So practical, during examination of muscle tone, during examination of motor system, we will go in details, right? So let me explain what is clasp knife spasticity, what is lead pipe rigidity, and what is very typical of PD is cogwheel rigidity. Okay, cogwheel, have you seen cogwheel? Cogwheel, वो घड़ी के अंदर जो सेटिंग्स वाला जो रहता है ना, सो एक दूसरे के अंदर सेट हो जाता है, तो ऐसे घूमता है, ठीक है? गियर मतो, ठीक है? Okay, so if you see a patient of Parkinson's disease, and say for example I am trying to he is a patient of Parkinson's disease, for God's sake it doesn't happen. Okay, so just assume he is a patient of Parkinson's disease. Now I am trying to extend his forearm. Okay, so if I try to extend his forearm, very simple, there is minimum resistance offered by the triceps muscle, and I get a slight resistance. This is normal muscle tone, right? This is normal muscle tone. But what happens in PD, if I try to pull it, okay, there will be resistance, but their resistance is not uniform. It is catchy. There are catches in between. Okay, so if I try to extend, it will be like this. Okay, so this is cogwheel rigidity. Okay, this is called cogwheel rigidity. So there is a resistance, but there are catches in between. Okay, this is called cogwheel rigidity, and this is a very typical of PD, Parkinson's disease. Okay, if you try to check the muscle tone of a patient of PD, you will see cogwheel rigidity, right? Okay, stooped posture is very typical stooped posture, right? And next, bradykinesia, slow movement, note chaichana, patient nodachara korte chaichana, right? Okay, so bradykinesia or hypokinesia or akinesia. Bradykinesia slow, hypokinesia less, and akinesia is absent movement. Then difficulty in initiating movement. Okay, so we can test it in the OPD room. You just ask the patient to walk. Okay, so patient will walk in this way, stooping posture, fascinating gait. Okay, so patient will walk like this. Okay, and suddenly you ask the patient to turn right. Patient is not able to do so and falls. Okay, so difficulty in initiating movement. Okay, so movement was uniform when you are asking the patient to walk along a straight line. So patient is walking, no problem, but there is a very typical posture, there is a very typical gait, fascinating gait, stoop posture. Okay, but still the patient is doing. But when you are asking the patient, suddenly you are asking the patient to turn right or turn left. So there is a sudden change in the movement and the patient need to initiate, and there is a problem. So patient cannot initiate new movement, right? Okay, so difficulty in initiating movement, legs freeze up, fascinating gait, postural instability and frequent falls, but no weakness. Okay, difference from pyramidal tract lesion. If there is a patient of hemiplegia, one-sided paralysis, hemiplegia, there is some tumor in brain, or there is some hemorrhage in brain parenchyma, right? What will happen? There will be hemiplegia, paralysis one side, and also there will be increased muscle tone. Okay, here in Parkinson's also there is increased muscle tone, and we are calling it rigidity. Okay, in cerebrovascular accident or stroke also, there will be increased muscle tone, and we call it spasticity. We do not call it rigidity, but anyway, it is also hypertonia, it is also increased muscle tone. But the problem is there will be weakness. Even if there is increased muscle tone, there will be weakness. If you test the power, I guess you don't know how to test the power of a muscle. The power of a muscle is tested by grade. Okay, grade from 0 to 5. Okay, maximum grade is the patient is able to raise with resistance. Someone will stop. Okay, and with against that resistance, I will try to move up. Okay, so if I am able to do that, it is grade 5. Grade 5 is normal power. Okay, grade 5 is normal power. Okay, 0 means no movement at all, and 1 means if you eliminate gravity, so I can move in this way. Eliminating gravity in a plane, I can move in this way. It is grade 1. Okay, so anyways, so muscle power can be tested from 0 to 5 grade. Grade 5 is normal, and essentially in cerebrovascular disease or stroke, muscle power is less, but in Parkinson's disease, in PD, muscle power is normal, that is 5 by 5. There is no weakness in pyramidal tract lesion or corticospinal tract lesion. Corticospinal tract পড়া হয়েছে? Corticospinal tract পড়া হয়েছে? হয়নি. Okay. So corticospinal tract is a tract that comes from your cerebral cortex to spinal cord that controls your muscle, mostly the flexor muscles. Okay, so in case of pyramidal tract lesion, that is which the tract which is typically damaged in cerebrovascular accident or stroke. Okay, stroke ki hoy corticospinal tract damage hoy, right? And when corticospinal tract is damaged, there is hypertonia, we call it spasticity, but there is also decreased muscle power. Okay, but muscle power is not lost, muscle power is preserved in PD. When you test the power of the muscle, it is quite preserved in a case of PD or Parkinson's disease. Okay, then what happens as because dopamine is decreasing, definitely there will be depression, okay, in Parkinson's disease. Then dementia, some sort of memory loss, sleep disturbances and difficulty in smelling. Okay, now it is not required for you, but as I am taking a class on PD, I am focusing a little bit on the treatment of PD, the treatment of Parkinson's disease. I repeat, treatment of Parkinson's disease is not required for a student in first professional MBBS. Treatment of Parkinson's disease will be studied in pharmacology in second professional MBBS, also during study of medicine in final prof, right? Absolutely, treatment of Parkinson's disease not required for physiology at first professional MBBS, but just for your interest, I am focusing few important drugs which are used in Parkinson's disease, right? Again, I repeat, you no need to remember these things. If you can remember, that is okay. If you are able to remember, that is okay, because it will help you in pharmacology and that will help you in medicine. But absolutely for your first professional MBBS, treatment of Parkinson's disease not required. No one will ask you the treatment. But the major treatment is, yes, the major treatment of Parkinson's disease depends on the physiology. So in that way, someone may ask you, what is the major treatment? Okay, what is the major drug? Okay, there are lots of our drugs. Say for example, 10 drugs are used for Parkinson's disease, but one drug is major. Okay, one drug is major, that is a must drug for Parkinson's disease, and its use depends on the whole physiology what we have discussed right now. If you do not understand physiology of Parkinson's disease, pathophysiology of Parkinson's disease, you will not be able to understand the drugs as well, right? So that is why physiology is taught first, so that you are able to understand the drugs or the actions of the drugs as well, right? Okay. So simply from your knowledge, whatever I taught till now, tell me what could be the treatment of Parkinson's disease? Yes? Yes, dopamine. What is less in brain? Dopamine. The neurons which secrete dopamine are lost. Okay, so you need to treat the patient with dopamine. You give the patient dopamine. Very simple logic. Okay, so in your basal ganglia, substantia nigra, there are few neurons which are supposed to secrete dopamine, and those neurons are lost. So simply give the patient dopamine. Okay, এটা সবার বলা উচিত ছিল. Anyways, okay. So treatment strategy, increase dopamine signaling. Main strategy of Parkinson's disease treatment is increase dopamine signaling. You need to increase dopamine, right? Okay, so but the problem is if you inject dopamine to the patient, okay, if you inject dopamine to the patient, or if you simply give dopamine tablet to the patient, what will happen? Dopamine cannot cross blood-brain barrier. We don't need dopamine in our blood. We need dopamine where? Here, right? Brain के अंदर dopamine चाहिए. Okay. But once you have dopamine tablet, if you give injection dopamine to the patient, dopamine cannot cross blood-brain barrier. There is a barrier, very effective barrier, blood-brain barrier. It cannot cross, it cannot allow, doesn't allow any substance to enter into brain. Brain is a highly secure zone, right? Parliament type of thing. So no one can enter without security checking, right? Okay. So dopamine usually cannot enter into the cerebral circulation. This is the major problem. Okay. Okay. So there is a solution. If this is the problem, dopamine cannot enter into cerebral circulation, we have a solution, and that solution is the precursor of dopamine, which is called L-dopa, levodopa. Okay, levodopa is just precursor of dopamine. Okay, from where dopamine is synthesized. Okay, so instead of dopamine, you give the patient L-dopa, which can efficiently cross blood-brain barrier. It can break the security, right? Okay, so dopamine cannot cross blood-brain barrier, but levodopa can, right? So levodopa or L-dopa then converted into dopamine by dopa decarboxylase within the cerebral circulation. Okay, you give the patient precursor of dopamine, that is called L-dopa. Okay. Now L-dopa enters into cerebral circulation, and within the cerebral circulation we have dopa decarboxylase, which converts L-dopa to dopamine. Now dopamine is available in cerebral circulation, and it can cure Parkinson's, not cure, it can relieve some symptoms of Parkinson's disease, right? Okay, so this is one drug, and L-dopa. Another problem is that if you give L-dopa to the patient, this dopa decarboxylase enzyme, this enzyme is also present in our peripheral blood. Okay, if you give the patient levodopa tablet, okay, simply giving the patient levodopa tablet. Okay, we need dopamine, but we are giving the patient levodopa, which is the precursor of dopamine, right? Now this L-dopa has to be converted to dopamine to work in Parkinson's disease, right? Now this conversion from levodopa to dopamine, it can occur here in the circulation, or it can occur here in brain as well. Okay, the enzyme required for this conversion is available here also in the peripheral circulation, also here in the cerebral circulation. Okay, but when I am taking levodopa, it is fast going into my peripheral circulation, it is not directly entering into my cerebral circulation. So in peripheral circulation, this levodopa, if it is converted to dopamine, then again this dopamine will not be able to cross the blood-brain barrier. Okay, so again we have a solution. So that solution is this levodopa, it is combined with carbidopa, a peripheral decarboxylase inhibitor. आपका peripheral circulation में जो decarboxylase enzyme है उसको inhibit कर देता है, right? So in the periphery, levodopa is no longer converted into dopamine. Only when it enters into cerebral circulation, then only it is converted to dopamine and works in Parkinson's disease. Right? Okay. So nowadays the drug which is available in the market, very frequently we advise the patients with this drug is called Syndopa, which is the combination of levodopa and carbidopa. Okay, combination of levodopa and carbidopa. This tablet is given to the patient. Okay, twice a day or thrice a day, whatever, according to the depending on the response. Now these are other drugs. I repeat, other drugs not required for you. Other drugs not required for you. Right? So amantadine, it is an antiviral drug. It is also used in Parkinson's disease. Then dopaminergic agonist like bromocriptine, ropinirole, pramipexole. Then COMT inhibitor, entacapone, tolcapone. COMT again is an enzyme which degrades dopamine. Okay, dopamine ko degrade karta hai ek enzyme hai COMT. Okay, so if we inhibit this enzyme, availability of dopamine will be longer for longer time, right? Then MAO-B inhibitor, monoamine oxidase, MAO, monoamine oxidase, MAO-B inhibitor, selegiline, it is also used in Parkinson's disease. And remember, in cerebral circulation, actually there is a balance between acetylcholine and dopamine, and this balance is important, right? So dopamine loss means relative excess of acetylcholine. So if you prescribe anticholinergic drugs to the patient, then also there is relief in Parkinson's disease. Okay, so the anticholinergic drug which is used in Parkinson's disease is called benjexol or benstropine, okay, or triacylphenydyl, benstropine. And nowadays a latest treatment, very latest treatment in Parkinson's disease is available, which is called deep brain stimulation. Okay, DBD or DBS, deep brain stimulation. Okay, chalo, thank you.